So today I'd like to talk to you about alternative methods for neuromodulation. Up till now, non-invasive brain stimulation has focused mostly on electromagnetism. So electrical and magnetic forms of stimulation really dominate the field. In our lab, we've used TMS in a variety of forms of electrical stimulation in a number of studies. We've looked at a variety of clinical disorders. We've also looked at memory enhancement, and the most technically challenging of that so far has been using closed-loop alternating current stimulation during sleep to increase memory consolidation. And we recorded brain EEG and were able to apply alternating current at the same phase and frequency as the subject's natural EEG. But the largest effect we've seen in any study so far has used TDCS that was guided by neuroimaging to produce a 2 to up to almost a 4-fold improvement in learning, a really large effect. So the stimuli we used are here. We had a series of still images. There were threats hidden in these images, sometimes snipers, bombs, things like that. People had to learn to identify them even though they were hidden. We did an imaging study and found areas that changed their level of activity as people learned to perform the task. And then we used those as targets with TDCS, and we found a doubling of improvement. We replicated this in a number of studies in our lab, and the basic design here was we obtained baseline level of expertise with still images, did training, and the training involved seeing a still image, making a yes/no response, and then the feedback was a movie. And if a threat was present and you said, no, I don't see it, then the movie showed the threat happening. This is called discovery learning. There's not much information being given, and it's a really difficult task and difficult form of learning. So we gave these stimuli to Raja Parasurman and Brian Falcone at George Mason University. They did an independent replication and found pretty much the same results that we did. Hit rate went up, false alarms came down, and D prime, a signal detection measure, more than doubled with using 2 milliamps of anodal TDCS current to the right temple versus the cathode on the left arm for 30 minutes. So this protocol and the results have been replicated a number of times. And across all these replications, we find a very consistent pattern of results. F10 is the right temple. We've also tried right parietal cortex, P4. And in all these cases, we see a significant improvement in learning relative to sham. We've also found that cathodal current over T5, this is left occipital cortex, showed improvement, but anodal current showed no significant difference. And if we compare these results to the original fMRI results, here you see the difference between threat present and threat absent after training. And areas that showed an increased response to threat present responded to anodal current, and regions that showed a decreased response responded to cathodal current, assumably reducing the level of activity in those areas. So fMRI did a great job of predicting the response to different electrode placements with really surprisingly good accuracy. So other imaging has showed us other things that might be relevant to this task. One is a series of studies by Huth et al. At Berkeley, and they found that the same area that we were targeting with TDCS responds to violent imagery. And it might have been looking for threats that produced this large enhancement. So Brian Gibson in our laboratory developed a new learning task. In this case, the task was to look at a series of images like this, and you had to identify what country each picture was taken from. Again, a very difficult task, not a lot of information given to make it work. But using the same protocol, we were able to get almost a 4-fold improvement in learning. Again, a really big effect. So from baseline through individual training blocks and then the post-test, people were able to improve both with anodal current and with cathodal current. So less of an improvement with cathodal current, but it was still there relative to sham. We've done a number of follow-on studies using this F10 TDCS protocol. And we're learning more about it, what it does, why it works, and so on. But there are other things besides learning that we want to tackle with neuromodulation, and one of them is addiction. So we had a paper come out in 2014 where we had tested 45 patients recovering from stimulant dependence. We tested them at about 1 month of abstinence and then followed them for up to 6 months. And at that time, after 6 months, about half of this population had relapsed to drug use. The other half had maintained abstinence. We compared the bold response that we got at 1 month of abstinence to see if there's anything in their brain function that predicted relapse. And it turned out that there was. There's an area in posterior cingulate cortex that predicted relapse with close to 80% accuracy. And adding a history of mania improved this accuracy to over 90%. So, and 84% using cross-validation. So it's a fairly good way, a good predictor of relapse. That suggests that activity in this part of the brain might be important for relapse behavior and addictive behavior in general. And if you look in the literature, most psychiatric illness includes cingulate or limbic system activity that has something to do or appears to have something to do with different components of those illnesses. So how do we target deep CNS areas without disturbing more superficial areas? There are methods for using deep TMS, but really they stimulate the whole brain simultaneously. So what are the basic premises of neuromodulation? It's that behavior depends on the nervous system function. The nervous system is a physical system, therefore functional physical changes in the nervous system should be able to change behavior. So how do we produce those changes? Before you try something, it's good to assess all your tools. You might just have a few, but it could turn out you have many more than you knew. So for neuromodulation, what are our tools? Really, our tools are energy. Energy is transmitted as forces, and there are 4 fundamental forces that we know about so far. The weak and strong force that have very short ranges and mostly have to do with holding molecules and atoms together. There's gravitation that acts across great distances, but is relatively weak, and electromagnetism. So because the weak and strong force act across such short distances, they're really not useful to us. And gravity, being relatively weak, and we don't have a good way to control it really, also isn't useful. So really, we've been doing the right thing. Most of useful forces are electromagnetic. If you look at energies derived from forces, there are a number of them. Some only act at very small or very large distances, so they're not really useful to us. So macroscopic energies, this remaining 10, are energies that we might be able to use to alter brain function. Chemical energy, the energy in chemical bonds, basically chemistry, are what pharmaceuticals depend on, and we've been using those for years. But we can't really direct them to specific brain areas without influencing most of the rest of the body. Electromagnetism, again, we've used that thus far, electric ionization and magnetic energies. But we're looking for something new, a better way to do this, or a different way to do this. So the remaining energies that we have are elastic, mechanical wave, and sound waves, which together explain ultrasound and its effects. Elastic and mechanical energy, which is simple physical pressure. Radiant energy, which is light, and thermal energy, which is heat. Now, most of these energies are actually acting through electromagnetism. And using these energies, we can influence electromagnetism indirectly by through these different forms of energy. So the first one I want to talk about today are mechanical waves and sound. So using ultrasound. These are kinetic and potential energies moving through different kinds of media. It's actually been known for almost a century that high frequency sound, what we now call ultrasound, can affect biological processes. So Newton Harvey found this out and published in 1929. About 30 years later, William and Frank Fry, a pair of brothers doing biological experiments, showed effects in the CNS directly using ultrasound. And here's just a little figure from that science paper that they published in 1958, showing that there was a reduction in visual evoked potentials using ultrasound. So, and Harvey's original work was in using frogs as an example. And by applying ultrasound to frogs, he was able to modify heart rate and other physiological processes. So this is a relatively old method, it turns out. Why should we be interested in ultrasound? First of all, is anatomic specificity. So with regular TDCS, not HT-TDCS, but regular TDCS, there's relatively broad swaths of tissue that are stimulated or altered with electric current. And with TMS, again, a relatively large area. With ultrasound, it turns out that modeling suggests you can get less than a centimeter of stimulation. So a relatively discrete and precise area of stimulation if you set up the experiment in the correct way. TDCS can have deep effects, but it's impossible to control precisely because electric current follows electromagnetic laws as it moves through the brain. And it's really difficult to force it to move one way or another using just surface electrodes. Ultrasound, on the other hand, by using multiple emitters all focused on the same area, can produce relatively weak effects until those different waveforms converge on a specific location. So our first study used a diagnostic imaging system and used a diagnostic imaging protocol with ultrasound, the same kind of protocol that we use in to measure and monitor fetuses in the womb. Doing this, Ben Gibson and Jay Sanguinetti in my lab applied 2 minutes of this imaging ultrasound protocol to the head and monitored brain excitability using TMS-evoked MEPs. And what they found was about a 30% improvement in MEP amplitude, or a 30% increase after 2 minutes of TES that lasted about between 6 and 11 minutes after stimulation. So we found, and other groups have found, that ultrasound can, applied to the brain, can affect brain function. How might we use this to impact drug use disorders? Well, we've started a series of studies where we used a focal ultrasound emitter positioned over parietal cortex, but directed towards the posterior cingulate cortex, where we found that big predictive effect of relapse. And in a series of pilot subjects, we identified the target location relative to the scalp location, positioned the emitter for each individual to direct the ultrasound towards posterior cingulate. And then you can see the ultrasound setup here. There's a system that generates the ultrasonic waveform in a controlled way. It's amplified, and then an oscilloscope can be used to monitor the ultrasound, and that's sent to the emitter. And this shows a bit of how the oscilloscope sees the ultrasound coming out. So basically, every few seconds, there's a tiny pulse of ultrasound over the course of about 10 minutes. The reason to space this out is partly heating, that we want to minimize the amount of heating being produced. So giving spacing between ultrasound pulses minimizes the amount of heat. We'll see later this might actually be part of the mechanism of the effect. So it might be something to think about doing it more quickly, but we're trying also to stay as far away from the safety limits as we can get. So we measured the effect on the brain using spectroscopy. And spectroscopy is an MRI-based method that can look at the concentrations of different metabolites in the brain. And by doing this, you can see for posterior cingulate, our target, but also other brain areas, what the effects are. And there's a method called EPSI that produces 3D MR spectroscopy. So it allows us to simultaneously see across the whole brain. And this allows us to look and see how large the effects are from ultrasound. And this just shows on a Siemens how we set up this protocol, this EPSI protocol. What we found were reductions in creatine, choline, and a combination of glutamate and glutamine, all within a centimeter or two of our target. So creatine is related to metabolism, also GLX, this combination of glutamate and glutamine, related to neurotransmission, and choline is related to membranes. All of them reduced a little bit during stimulation. So in conclusion, we found that the effects of ultrasound, some of them have been known since the late 1920s. It's thought to be safe if used below certain thresholds. Neuromodulation applied in those thresholds produces changes in the brain that we can see. So now we're planning to use this in a series of studies, first to see if we can reduce smoking. But given that nearly all forms of psychiatric illness involve deep brain structures, this may prove to be a very effective method for altering brain function in a way that will produce improvements in behavior in different psychiatric illnesses. How else can we use energy to alter brain function? Radiant energy is another way. So using light. And light therapy has actually been practiced for thousands of years. It's not clear if the early forms of it worked. Light therapy was developed for biomodulation in the Soviet Union, now Russia, as early as 1964. And there's a nice summary article from 2017 that you can look up if you're interested to learn more about this. Today, there's a number of commercial methods available. One of them is made by a company called V-Light, and they make a device called the Gamma Neuro. So the Gamma Neuro uses 810 nanometer pulses. It's pulsed at 40 hertz for about 20 minutes. And it uses LED emitters that are spread around the scalp, and one goes up the nose. And we use that same threat target detection task that I described to you earlier to see what the effects for the V-Light might be. So we use the same task, again, a baseline training and test. And during the training, we either applied infrared light in that 40 hertz pulse manner or a sham. And we looked at the change in performance with training. We found that using this, we again got about a doubling of learning, applying infrared light for 20 minutes with a reasonably large effect size and Cohen's d of 1.4. So a fairly large effect. We wanted to replicate this, and we got a new Gamma Neuro device that had slightly different properties and tried to replicate and saw no effect. We went back to the original device and found that, again, we got a reasonably large performance improvement. So what was going on? It turned out the difference between these two devices was that for the original device, the posterior and anterior uh, phase of light was 180 degrees out of phase. So the back system would pulse, then the anterior LEDs would pulse, and back and forth. The second system, both lights pulse simultaneously. So we asked them to make a new device that pulsed out of phase again. Tried that again, but lo and behold, no effect. So it may be that that initial result was spurious and just a statistical anomaly. But we're trying a third time using those original devices again, but this time in a double-blind manner. So two possibilities are, there's something about that original device that produced this relatively large change in behavior, or it's the fact that when we ran this first, we used a single blind method. So the experimenter knew the condition. In the second and third attempts, the experimenter didn't know the condition. So we're going back to those original devices to see if we can get the same effect. So this is still work in progress. I don't know what the end result's going to be. Hopefully when the coronavirus lockdown ends, we'll be able to get back into the lab and try this. What's another form of energy that we might use? Another one is mechanical energy, physical pressure. So this is a little different than these other forms of energy in that you can't really apply pressure directly to the brain safely, but you can apply it to the body, basically to the peripheral nervous system. And over the years, there have been a few different methods that have been developed to be able to use pressure in a way to alter behavior. For a long time, we've known that humans like to bite when either they're trying to produce strength, when you're doing lifting or something like that, you tend to bite down, but also for pain. And for years, people would bite when they were in pain. So when they did surgery, before they had anesthetics, they would give you something to bite on, or when women were in childbirth, they would give them something to bite on. Other places in Asia, there were methods of acupressure developed where just pressing on the body was thought to produce changes in how body function and behavior. Another method is one by Temple Grandin developed. Temple is a woman with autism, but very smart. And she realized working with cows that they had a machine to hold cows while they did work on the cow, and the cow would calm down. She tried it on herself and found that she calmed down. So there are a number of methods in the past that have used pressure. However, in the modern day, there's a new method that is in development. And this uses pressure on the teeth and jaw to treat neurological disorders. Brendan Stack and Anthony Sims are two there's actually a number of dentists now working on this, but Brendan Stack was the first. And what he saw was that when he treated teeth and jaw disorders in patients that also had neurological disorders, a number of times that neurological disorder would improve. And follow-up work by Anthony Sims and other dentists have shown this to be true, that treating dental problems can actually have an impact on the nervous system. Now, I learned about this because of a neurological disorder that my son Ryan developed a number of years ago. So he's a great, wonderful kid. And as he was growing up, started to do a lot of physical things. One day in gym class, he twisted his knee and his ankle and knee. And he had to use a pair of, well, he couldn't walk very well. So he was either in a wheelchair or used crutches for a while. But he got better. And then a few months later, developed a pain syndrome. And this syndrome involved a lack of blood supply to the affected leg. And you can see the difference in color here. It caused a lot of pain for him. We took him to a doctor. The doctor gave him medications that helped with the pain, but it produced a really horrible side effect where he would develop tics. He would just fall down and go into seizures. Sometimes he would get dystonia where he had real trouble moving. And eventually we were able to treat all this. And as of today, he's doing great. He was valedictorian for his high school class. He's in an honors engineering undergraduate program at Arizona State. We got through this, but how did we do that? It turned out that by adopting the methods developed by Brendan Stack and other dentists, we were able to get him to the point where we could calm down his tics and reduce his pain. So we came up with a non-pharmacological method to treat his pain and his motor symptoms. And this shows by just having him bite down on something, he was able to get up and walk for the first time in over a month, just using a stack of bite guards that he put in his mouth. So again, it was difficult, but not impossible for him to walk. And other patients have shown
my
some
symptoms were twitching. I had barking noises. I'd twitch my neck back and forth, cause myself whiplash. I mean, I've always looked at people and just wishing that I could just stay still.
So that was a patient that had Tourette's syndrome, and just by biting on a orthotic, a mouth guard, he was able to reduce his symptoms. And other patients with a variety of symptoms. Here, this patient has blepharospasm, here Tourette's syndrome, here dystonia, and here tics and dystonia after CRPS, like my son Ryan. All of them benefited by just putting a stack of tongue depressors in their mouth. How does this work? There are three likely scenarios. One of them is it's purely psychological, that there's no neurological basis to this, that for whatever reason, people are able to have their symptoms go away just by the belief that they would be helped. Another is that there's something special about the temporomandibular joint in that when it's irritated or pain is caused by a problem with the jaw or teeth, that this somehow propagates into the nervous system and causes effects that part of those are changes in brain networks, and that by having them bite, this normalizes those brain networks and reduces pathology. A third possibility is that the nervous system, the peripheral nervous system in the jaw, is actually designed in such a way that it's sensitive to pressure on the jaw and teeth and is designed to alter nervous system behavior that way. So we've done a number of studies, one of them looking at MRI. And while people have one of these devices in their mouth, you see that the condyle, the end of the jaw, moves out of the articular eminence and away from, assumably, where the nerves that innervate the jaw tend to run. So it's taking pressure off of those nerves. We've also done fMRI, and we found that using devices of different thicknesses and have people doing a motor task while they bite down on these devices, the thicker device, the larger the effects in the brain of biting down. So this uses a very thin device as a sham device and a thicker device as an effective device. And you see more effects in the brain as people bite down on thicker devices. And the largest effects of these are in the cerebellum. We've also done studies with blinking and find that, again, with clenching an effective device during blinking versus rest, that you see effects in the brain when they're clenching versus not clenching. And the interaction of these, so movement, blinking versus not blinking, and clenching versus not clenching, looking at that interaction, there's a significant effect across a variety of brain areas, focused in the caudate, a little bit in the cerebellum, but also a bit in frontal and parietal cortex as well. So we're finding effects here in the brain using these methods. We published a short paper in Pain Medicine on this method. And as of today, there's many remaining questions about it. If tics are in all muscle groups, why should biting, that is dealing specifically with the jaw, have any effect on these other muscle groups? Why are we wired that way if it's true? How would problems with the trigeminal nerve, say from temporomandibular joint illness, lead to changes in brain function that's seen with fMRI? And assuming that overstimulation is causing these problems, why does it selectively cause just some motor illnesses and not others? How are genetics involved? And these illnesses tend to wax and wane over a patient's lifetime. Why is that? Are these changes in the jaw that are causing these problems? So there's a lot of questions. So in conclusion, there's a number of older technologies to affect neurological symptoms and behavior. Oral orthotics are a relatively new technology, but along the same lines. Dentists working with patients have found that patients with Tourette's, Parkinson's, dystonias, and complex regional pain syndrome, like my son Ryan had in the past, all can benefit from oral orthotics, oral appliances. So, and we found some consistent fMRI effects so far, suggesting that there are actually brain effects of using these. So if we understand this better, this might provide many new and more effective treatments for dystonia, chronic pain, and other forms of illness. Finally, and really quickly, heat may be an important property of, or an important side product of a number of forms of neuromodulation that alter brain function. And there's a number of papers coming out showing that different forms of stimulation, like kilohertz frequency, brain stimulation, and ultrasound, might both have heat as a mechanism of effects on brain function. So we haven't, in my lab, done any studies like this yet, but there could be a number of effects that we need to look at that involve heat. So what's the future of non-invasive brain stimulation? Really, it's a combination of developing new technologies and making older technologies more effective. But I believe that the future of non-invasive brain stimulation is really us looking at every energy possible, looking at its advantages and disadvantages, and seeing which of these might ultimately produce positive effects in the brain. And the future, besides finding new methods, I continue to believe involves neuroimaging. So knowing the physical basis of a cognitive process and how it goes awry in different illnesses will guide us in the application of non-invasive brain stimulation. And the more that we can incorporate neuroimaging into this, the better we will do. So having more tools in our toolbox allows us a greater variety of methods to correct problems indicated by neuroimaging. We still have a lot of work to do, but I'm hoping everyone watching this that is involved in this research will understand that the more we can incorporate into our toolbox, the more we'll be able to accomplish. So finally, thanks to many, many people that have been involved in these studies and our granting agencies that have been very helpful in performing these studies. And thank you for listening.